So good afternoon. My name's Anita Makins. I'm a consultant and obstetrician and gynaecologist at the John Radcliffe here in Oxford, and I also work for FIGO, the International Federation of Obstetricians and Gynaecologists, whose headquarters are in London. And I'm going to be talking to you about the impact of COVID-19 on sexual and reproductive health at a global level. So I'm sure, as you're well aware, the COVID-19 pandemic really took the world by surprise. The turn sort of from January 2020 onwards, really February and March and so on, became a real problem here in Europe, and gradually it spread from China, where it originated, to Europe, to the Americas, United States and Southern America, and now Southeast Asia. So to date there are 27 million cases with 900,000 deaths recorded this far, so nearly 1 million deaths. And the hotspot at the moment in terms of the places with the highest number of new cases is Southeast Asia, although the Americas still carry 52% of cases worldwide. So the first thing really to think about is this data that we're getting, because we look at data all the time and the newspapers have it all the time, and it's just interesting really how it's recorded and how it's reported. I'm Brazilian originally, so I was very interested in what's going on in Brazil, and this is an excerpt from a comment by the mayor of Manaus. Manaus is the capital city of the Amazon state in the north of Brazil. And when the infection started in Brazil, the Amazon was particularly badly hit, but it didn't really reflect in the numbers very much. But this is what the mayor said. He said, we aren't in a state of emergency, we're well beyond that. We're in a state of utter disaster, like a country that is at war and has lost. We don't have hurricanes here, we don't have tsunamis. Here the tsunami was having disregarded social isolation. So he, at the start of the pandemic, felt very isolated. He didn't feel he got help from his central government. The picture on the right, they started opening mass graves because people were dying at numbers that were so fast that they didn't actually have safe places or any place to bury them. And you can see on the left, obviously, the indigenous population of the Amazon. Very difficult balance, in the absence of COVID, but certainly with COVID they've been hard hit, and the infection basically ran down the main river that runs through the Amazon, and the tribes along the way, people got infected, and a lot have died. So really an issue, but it didn't, as I said, it didn't really reflect in the numbers, and I just wanted to explain why that was. So this map shows the distribution. On the left, A is number of cases, and on the right, B is number of deaths in the different states of Brazil, and the Amazon is the one in the top left. And you can see, so just this is the Amazon here, and you can see for sure, the darker blue are the most number of cases. You can see a lot of cases in the Amazon, but similarly a lot in São Paulo, which is a big city, and Rio, and up in the northeast of the country as well. So a lot, but not necessarily more than anywhere else, but the reports were horrific really from the Amazon in comparison to what was going elsewhere. So then if we then look at these numbers per 100,000, per million inhabitants, you can see here that the Amazon immediately is the hotspot, because actually the population in the Amazon is very low, and so when you look at the number of cases and the number of deaths, you can see that it was indeed hard hit, and if the government had to sort out where it was going to send its support and supplies and human resources, that was the place that needed it. And gradually, as time went on with the pandemic, people learnt better how to look at measures of infection. And so this one, again in Brazil, is looking at the number of episodes of people being admitted to hospital for acute respiratory syndrome of some sort, and it compares 2019, which is the greeny line, to 2020, which is the dark blue, and you can see there, as the weeks went on during the pandemic, there's huge difference between what was happening in 2019 to what was happening in 2020. Imperial College in London have done a huge amount of work during the pandemic in terms of releasing information as quickly as possible. Obviously, you know, most people want to look at peer-reviewed journals because they're peer-reviewed, and so it sort of guarantees quality, but actually information had to come out as quickly as the pandemic was going on, and so in that sense Imperial College was a little bit ahead of everyone else, I'd say, in what they published. But they published a very interesting report in May called Equity in Response to the COVID-19 Pandemic, an assessment of direct and indirect impacts on disadvantaged and vulnerable populations in low and lower middle income countries. And what they were pointing out was that the strategies that were being used in the high-income countries were not going to work in low-income countries. And so here we're looking at access to water, people's occupation and access to health. So the top left graph is looking at percentage of households with soap and water. And you can see with the wealthiest quintile on the left, you can see there you know, over 50%, so close to 60-70% of people in the wealthiest quintile would have access to soap and water in these countries. And then as you move along to the poorest, which is a dark red, the dark red, you can see here that very few people have access to soap and water. And really that is the basic starting point really with prevention of a spread of infection, is washing our hands, and not only washing our hands, but if you're in your UK or following WHO guidance, it's washing your hands for a long period of time with soap. So that is already not possible. Then if we look at the second graph at the bottom, that's looking at the percentage of occupations where people could actually work from home, which is what, you know, the high income countries did, what UK did, France did, etc. Everybody had to work from home, and you can see here that the wealthiest quintile, you know, 25% of the population actually can perform their work from home. And as you move round even to the middle poorest quintiles, it's just not possible. If you earn your living selling things in the market, you can't do that from home. And there are numerous examples of the way people earn their living in low and low middle income countries who would not suit working from home, so just not an option. And then actually if we look at access to health, these are both the two graphs, you can see there distance to the nearest hospital. So you've got the wealthiest, the vast majority are going to be travelling under 25 kilometres, but as you move on to the poorest quintile, you can see that many people would be travelling a long way to get to hospital, so access to health being a big issue. So they put all of those three things together and looked at the compound impact of those three, and you can see here that they were predicting that there would be a 32% increase in the probability of death in the poorest quintile when you compare it to the wealthiest quintile. So really something to take into account when you're trying to come up with strategies to minimise infection rates in these countries. So for obstetrics and gynaecology, we can look at it in two ways. You can firstly look at the direct deaths from COVID infections in pregnancy, and the reality of that, or what seems to have become apparent, is that actually a pregnant woman is not more susceptible and doesn't get more sick than a non-pregnant equivalent adult woman. What's not clear yet is the extent of maternal to fetal transmission, and certainly not clear with regards to what happens with infections in the first trimester and whether that can impact in some way in the development of the fetus. So that's still an unknown. In terms of indirect impact, so this really is where the big problem arises. An increase in morbidity and mortality related to the fact that people won't be accessing health in the same way. So this enhancement of what we call the 3 delay model in obstetrics, so decision to seek care, the ability to actually receive care, the ability to reach the healthcare centre and then actually getting healthcare when you arrive. So these 3 delays are greatly enhanced by COVID-19. Secondly, the increase morbidity related to the non-use of contraception, so more pregnancies, and in line with that is the risk of increased unsafe abortions. And so when we look back at other epidemics that have happened in the world, like for example the Ebola epidemic, this is taken from a paper published with regards to what happened in Guinea during the Ebola epidemic, and you can see there that antenatal clinics dropped dramatically during the peak of the Ebola period, and the graph on the right is looking at number of family planning methods, total number of combined pill injections, IUDs and implants, and you can see that during the peak of the Ebola period that dropped massively, so a drop in the use of family planning methods or accessing family planning methods. So this is of great concern. So contraception, what the FIGO statement said was that contraception and family planning are essential services and a basic human right, and the consequences of the non-provision of these services will result in morbidity and mortality far in excess of that related to COVID-19 pandemic alone. So these are more far-reaching than just the morbidity and mortality related to the woman herself, but to her children, family and to society. So in terms of the prediction that has been made, so this is a table taken from a paper written by authors at the Guttmacher Institute, and what they estimated was a 10% decline in the use of short and long-acting reversible contraceptives would result in an additional 48 million women with an unmet need for modern contraceptives, and hence something around 15 million additional unintended pregnancies. So a 10% decline in service coverage of essential pregnancy-related and newborn care. You'd have there an additional nearly 2 million women experiencing major obstetric complications, 28,000 maternal deaths, 2.5 million newborns experiencing complications without care, and 168,000 additional newborn deaths. And in terms of abortions, from moving from safe to unsafe, we thought there'd be an extra nearly 3.5 million additional unsafe abortions with added maternal deaths as a consequence. So really very concerning in the long run. So I put this slide in just for those who are unaware of the consequences of the lack of birth spacing. So there's a direct correlation between birth spacing and the chances of those children who are alive continuing to be alive and not undernourished. So the less birth spacing there is between pregnancies, the less likely the children are to be alive and not undernourished. And so you can imagine, if there's no access to contraception, how that's going to impact not the woman but also her wider family and her children. So what can we do, or what can the world do to mitigate all of this? So FIGO released a statement in April where it came up with 6 really key points to consider. The first one was enhancing postpartum family planning. Second is the supply of administration methods, removing barriers to access to contraception, the use of telemedicine and preempting these supply issues, and ensuring PPE. So in terms of postpartum family planning, the obstetric encounter has become a golden opportunity now for integrated healthcare. So if women are not going to access health services, then the majority probably will still come to hospital to give birth, although we have heard from many countries that even institutional birth rates have dropped quite dramatically, for example in countries like Bangladesh. But when the woman does come to hospital, that's an opportunity to offer more than a safe birth, so that we should be thinking about contraception, that we should be talking about contraception with the women and offering it, and the using particularly the long-acting reversible contraceptive methods like implants, IUD and IUS. So these can be inserted postpartum, PP-IUD, and are particularly valuable and cost-effective. Secondly, the self-administration methods. These should be actively promoted. So if we're giving the pill, then you're giving large surprise, let's say 6 months worth. So if we're providing emergency contraception, instead of instead of intramuscular medroxyprogesterone acetate, so depot injections, we should be using the cyanopress version, which is the subcutaneous. a plentiful supply of barrier methods, and that women really understand what the lactational amenorrhea, how to use it properly as a contraceptive method, and also vaginal rings. So the fact that the rates of domestic violence have also increased, and so self-administration methods become even more important. Thirdly, to remove barriers to access, so simplify processes, decentralise services so that people can make decisions at hospital level about how to redistribute their stocks, where to send staff, maximise task shifting and task sharing, so give midwives an increased role so there can also be counselling women on family planning and administering methods, so postpartum, the postpartum IUD, for example, in the FIGO initiative, midwives were highly competent, perfectly able to insert the IUD postpartum. And to remove unnecessary barriers, so to ensure, for example, that pharmacists can give medications over the counter more freely, and really to just facilitate things for women. Fourth, the use of telemedicine, so many pilot interventions in low middle income countries have used telemedicine, so we need to put those in practice, so use mobile phone, websites, call sites, use social media, and think about actually home delivery of goods, home delivery of contraceptive methods, etc. Supply chains. At the start, there was huge concern about the supply of contraceptive methods. UNFPA supplies 46 low middle income countries with contraceptive methods, and what they realised very early on that they were going to have issues with shipment of components used in manufacturing contraceptives from China, that they had issues with their factories in China actually producing the methods, and that border transport was going to be disrupted. So the prediction was that there was going to be 47 million women with less access to contraceptive methods, and that that would increase by 2 million every 3 months that these lockdowns continued. So what they did was started producing this COVID-19 update on a quarterly basis, really outlining exactly where the problems were and working with partners in country to try to overcome these problems, moving supplies around and just rationalising their use. What this whole pandemic to me has highlighted is just how fragile the supply chains for contraceptive and other essential medicines are. You've got there at the bottom of their table life-saving maternal health medicines, so oxytocin, misoprostol, magnesium sulfate and calcium gluconate, so essential drugs to look after sick women when they go into labour, and distributed by one sole provider is just really concerning. And so I think globally we need to be thinking about how policies need to be changed in order that we can ensure that this kind of situation doesn't come up again. So number 6 is PPE. So I think a transparent sharing of information about the situation in country, about the situation in terms of provision of PPE, so that healthcare providers really are informed and know how to protect themselves and to continue to offer services safely. And you've got their examples on the right, that's masks being sold in a market in Mozambique, and the bottom is, as in Brazil again, sort of just local women putting PPE together because stockouts were certainly a common situation at the start with the pandemic. So on the positive side, in terms of how LMICs deal with all of this, I think there are various lessons to be learned out of all of this. Firstly, that LMICs are very much more used to dealing with infectious outbreaks and emergencies than high-income countries are, and in that sense they're sort of ready to deal with it much more so than their richer counterparts. Low-income countries are familiar with task shifting. Midwives, for example, in sub-Saharan Africa and also in Southeast Asian countries do a lot more than they would do, for example, in Europe, and so this can be capitalised on, including, for example, with postpartum family planning. Community health workers exist, they're normal structures, and again in sub-Saharan African countries they're the norm, so they could be key to testing and tracing infected cases. Self-administration models, methods have been more commonly used, so subcut injection of Depo-Provera is commonly used in sub-Saharan Africa and distributed by community health workers, and so we need to capitalise on these. And then there's been examples, for example, in Bangladesh, where the TB gene expert were converted to COVID-19 testing hubs, and that meant that Bangladesh could very rapidly expand its testing capacity to areas of the country which you would have thought would be hard to reach. And being flexible and coming up with new ideas and so on is routine in clinical practice in low middle income countries, which is not the case in high income countries. And it's been very interesting for me, for example, living through this period, working in somewhere like Oxford University Hospitals, but previously having worked in low income settings, really, how different health systems cope with this sudden extreme situation, which is the pandemic. So you've got here a slide with further reading in case you're interested, but other than that, I'd just like to say thank you very much for listening.